Speaking of pain, Dr. Adam Kaplan, no, I'm just kidding. I can do it to him because Adam knows I love him dearly. So third talk of the morning, as we go through a lot of the issues that people deal with, this is one that is pervasive. I actually, when I'm talking to patients about mood, depression, the blues, etc., I remind them that it's statistically near impossible to go through what you have gone through. Being in an emergency room, getting a diagnosis of a rare disorder, feeling like you're alone, having a part of your life taken away from you over a period of minutes, hours, or days, and a frustration in terms of trying to get it back. It is statistically impossible for you to come out of that experience the same person you were as before that experience. Some of the changes may be for the good. Some of the changes may be that you have certain appreciations of things in life that you didn't have before. Some of the changes may impact your daily functioning. And for a lot of our patients, a lot of our parents, a lot of our families, the lump term depression doesn't encompass all of the different challenges they face. But for many, depression is an appropriate title for what people are going through. And this is critically important to have addressed. There is nothing symptomatically you're going to hear about today that isn't impacted by your mood. If you are optimistic about your pain control, your pain is better controlled. If you are optimistic about your functioning, your fatigue is better. And sorting out the causes and the strategies to treat depression are a high priority. The mistake we make as physicians in general is we think about depression and you're talking about pain, you're talking about cognition, you're talking about fatigue, and all of a sudden I say, well, how's your mood? And people instantly say, he's not listening to me. He thinks this is all in my head. There's something going on in my head. He thinks I'm nuts. I don't think you're nuts. Well, actually, there's a couple in here, but you know who you are. For the rest of you, I don't think you're nuts. It is an issue that we don't communicate well with our patients about. There is no better person in the world in terms of communicating these issues than Dr. Adam Kaplan. He's on faculty at the Johns Hopkins University. He has appointments both in psychiatry and neurology. He's been part of the Transverse Myelitis Center since its inception and has worked there and internationally with patients both on the physical and the mental, and I was thrilled when he accepted the invitation to come down and talk to everybody about depression in the setting of these rare disorders. So, Adam, I'll turn it over to you.
Great, thanks a lot. So I just need to make sure I know, is this advances, and this is the, great. Oh, there's an even better laser pointer. It's all about how you use the tools, not what they are. So thanks very much. And again, I think that this, Ben talks about the trifecta. We're talking about above the neck issues, and we're sort of all crammed here in the morning with pain, fatigue, depression, and then we'll have cognitive impairment in just a little while. So these are the four horsemen of the apocalypse. It's hard to talk about depression without depressing everybody, so that's my task to move along. But it is, I will make the argument right up front. Everybody has, is sort of their own area, and so they're biased and the like. But I'm going to try to persuade you that this is, number one of the most misunderstood aspects. I'm going to talk about the neuroimmunology, how this is really the same as all the other aspects of your disease, and no one's saying, it's impossible to sort of go through this experience without having intractable pain. I mean, no one would say that, or it's impossible to go through this experience without having cognitive impairment. No one would say that these are phenomena that come from the MS. People with ALS have rather uncommon rates of depression. ALS, Lou Gehrig's disease, from diagnosis to death, guaranteed in 3 years, and yet rates of depression are very uncommon in that disorder, right up until the point people die. So this is not just a reaction to stress. But what I will try to convince you today, in the next half hour, is that of those four horsemen of the apocalypse, depression is unique for the following reasons. Number one, it underlies the other three. Depression worsens cognitive impairment. I'll show you that it's one of the symptoms of depression is cognitive impairment. It worsens fatigue, another one of the symptoms of depression, and it worsens pain, okay? So it underlies those. If depression is in the room, the rest of them sort of take a back seat in a sense, because until you get the depression under control, you're not going to be able to manage the other ones effectively. The other thing that's important to remember is that it's the most treatable okay? It's the most treatable of all four of those apocalypse, but it's also the one that will kill you. Okay? That depression has a suicide associated with it. Suicide is, you know, the number 3 cause of death in MS in the Transverse Myelitis Center at Johns Hopkins. It has vied for the top 3 as well, between 1 and 2, if not the number 1 cause of death. So if you don't take it seriously, it has a significant morbidity, a significant mortality. But, like I said, as you've heard today, very hard to manage pain, very hard to manage cognitive impairment. We don't have great treatments. Kristen Ron, who's here with me, is working very hard on coming up with animal models. But it is very hard to, we have no good treatments for cognitive impairment. The difference is when you deal with issues of depression, the expectation is to get someone 100% recovered from their depression, okay? 100% back to their old selves. So with that in mind, now let me see if I can actually convince you of this. I'm reminded of my daughter's favorite joke when she was a little younger. She's 12 now, so she gets upset when I attribute this to her because she's too cool for school now. But when she was about 8, she loved the joke and loved to tell the joke. A man walks into his doctor's office with a duck on his head, and the doctor says, "May I help you?" And the duck says, "Yes, can you get this man off my butt?" And what it reminds me of is to tell you that sometimes what the doctors are focusing on and what seems like the duck in the room is not actually what it looks like. It may be an underlying depression, and it's important not to miss it. So by way of disclosures, I'm going to tell you, I loved Mr. Abraham's discussion about keeping a calendar. We've come up been working hard to launch now Mood 24/7, which essentially uses, you can register, it's free. I'll show you just one slide about it in a minute, in a few minutes. And basically it's a way of using your cell phone to keep that calendar. So it says, how's your mood on a scale of 1 to 10? You type in your mood and it keeps the calendar for you. You share it with your doctor. They can log on and actually see what the mood is. But I'm not going to tell anybody if you use it for pain or fatigue or whatever your favorite scale is, okay? So it's totally free. I am completely biased and therefore I must disclose because, I'm the inventor and co-developer, so it's like talking about my child and very much an issue that I need to disclose. But again, just to dispense with the idea that depression is an inevitable consequence, I'm going to talk about MS because MS is 10 times more common than transverse myelitis and, much more common than even rarer conditions like ADEM and NMO. So that's where I'm going to draw from, but I will show you that it's the same story in MS and these other central nervous system autoimmune diseases. But this was a study that was done at UCSF in San Francisco, obviously, and basically they got on the phone and they called people and they said, how has your MS been affecting your life? And what was interesting is that 20%, 1 in 5, said that it put strain on their relationships, and that's not a big surprise. This is a chronic condition. It affects the whole family. 30% said that they were demoralized. They made statements that were categorized as demoralization. And that, again, isn't a surprise since depression in the MS clinic and TM clinic, by the way, affects 25% in cross-section. At any given time, 1 in 4 people with these CNS autoimmune diseases are suffering from a clinical depression, not just G and be depressed too. We're talking a clinical depression that results from inflammation in the brain. But what was really striking is that 60%, okay, twice as many as were demoralized statements and 3 times as many as people said they were strained, gave answers and they didn't know how better to characterize them than to say that they were somehow benefit finding, meaning that somehow MS had actually benefited them in some way in their lives. Now I know everybody's thinking this is California where medical marijuana is as common as Starbucks, but that wasn't the answer actually, because when they gave sort of the specifics in the paper that was published, people endorse things like my friends and family have become more helpful. I'm closer to my family. I learn, more about what's important. And when I use my daughter again as the excuse for why I watch American Idol. But when I see these kids, going crazy and saying, if I don't get on American Idol, my life is over. I want to shake them and say, the best things in life aren't things, and you don't really appreciate priorities until you're confronted with some kind of event. And these autoimmune diseases are these kinds of events, and I've had a number of fathers who now stay home more, get to know their kids for the first time, that it has made people more compassionate. And it is a privilege to work with patients and their families who have these diseases because, each day is somehow more important. And, I see people at these conferences talking and going right into very personal matters because, you live life at a little bit of closer to the bone, a little bit more important, and a new set of priorities. So this is Cody Unser, who says if you can't be normal, be spectacular, and that's fabulous, and I'm a huge fan of Cody Unser's. Cody was told very early on at the age of 12 she got transverse myelitis, and she was told you're never going to be normal again. She said, okay, if I can't be normal, I'll choose to be spectacular. And Cody, I talk about her as Diamond Cody because she started off, luckily she's not in the room, but I will go on record as saying she started off as a 12-year-old who, when she first was introduced to me, said, "You're a psychiatrist. I hate psychiatrists. You guys aren't real doctors." So she started off as a bit of a brat, and I call her Diamond Cody because she started off more as a lump of coal. And I think she would agree that as a result of the tremendous pressure she was put under, she just lobbied Congress, was just speaking with Francis Collins, the head of the NIH, et cetera. And she is an amazing woman, in part because of the way she's risen to the occasion. And I recommend you watch her documentary. It's very telling. But for those of you who look at Cody and say, wow, that only makes me feel worse because I'm nowhere near to where she is and I can't even imagine getting to that place, what I tell you is you need to consider the things that are in your way, the things that you have to overcome. Now, this is Hippocrates 2,400 years ago. He described this condition called melancholia, and melancholia is what we now call depression. We've had depression in our medical literature for 2,400 years. And yet, what's interesting is that Hippocrates said, this is the result of this black bile. Okay, they didn't know anything about serotonin or epinephrine, anything like that. He said it's the result of this black bile that gets into your, oh, that's interesting. You can advance it with another button I found underneath. So this black bile gets into the brain, monkeys up the work of the brain, and results in depression. And I'll tell you, that's a pretty modern description of depression, and one that we're only now getting back to 2,400 years later. So the one thing depression isn't is just normal sadness. And what I like to tell the residents in medicine when I'm trying to teach them about depression is, people say, oh, I got really depressed. I saw that movie last night that was so depressing. And they don't mean that they went home that night and had to take Prozac because the movie was so depressing, right? They mean that they were sad. If you're not sad at some point in your life, you're not paying attention to what's going on around you. And what I like to point out is that sadness is just one symptom, but you don't even need sadness, by the way, to get the diagnosis of depression. Sadness is to depression what cough is to pneumonia. Cough is just a symptom. Someone will cough during the course of this talk, and it's not going to be from pneumonia, dry air, asthma, etc. So cough can be an indicator of pneumonia, but not every cough is the result of pneumonia. Sometimes pneumonia presents without a cough, particularly in the young and the very old. And you also get equivalent symptoms instead of sadness leading to depression. You get equivalent symptoms that is actually irritability. Now, I know no one in this room has ever been irritable as a result of mood changes, but that certainly is one of the equivalent symptoms. So you really need to consider the company the cough keeps. If it's a productive cough and you look at the chest x-ray and you see this white area and someone's breathing quickly, we call that pneumonia. What do we call depression? Well, you have to have 5 of these 9 symptoms for greater than 2 weeks. And these symptoms include decreased sleep, in particular, early morning awakenings. Lots of times we're making lists in our head as we go to sleep, and we're not really sort of able to drift off to sleep. But people who find themselves waking up early in the morning, unable to go back to sleep, waking up with that same sort of negative feeling that they went to bed with, that is just one symptom. That doesn't make the diagnosis, but that's the kind of symptom you see with depression. Decreased interest or decreased pleasure, people's get up and go has gotten up and gone. Feelings of guilt or worthlessness, and this is why people say, I don't even want to burden the doctors with talking about this. This gets in the way of people's care, gets in the way with their ability to engage in their own rehabilitation. Again, fatigue. That's one of the cardinal symptoms, right? We heard about fatigue earlier. It's one of the 9 symptoms of depression. The kind of fatigue you see in depression, unlike in CNS autoimmune diseases like MS and TM and NMO, is that rather than be more in the early evening, late afternoon where you hit the wall and fall off to sleep when you're at your desk or watching television, it's the kind of fatigue where you wake up in the morning and you're fatigued to begin with, and it maybe only gets worse during the day. You should be recharged in the morning, and if you're fatigued all the time, that is one of the symptoms that may, if you've got the other, you need 5 of 9, if you've got the other 4, would be something that would make the diagnosis of depression. And here's that mood. Again, mood can have its equivalent, which is irritability, but sadness is just one symptom. Concentration, and again, that's cognitive impairment. And we've had people in nursing homes who we treated their depression, were diagnosed with Alzheimer's disease, and they go home and live independently. It can be devastating, the cognitive impairment of depression. It can look like dementia. Either weight gain or weight loss. For women, it's chocolate. For men, it's salty foods in general, but that's a generalization. And then psychomotor agitation or retardation, and what that means is people who really know you and love you can look at you and see you're not as bubbly or ebullient as you normally are. And then thoughts of death or suicidal ideation. If you have 5 of these 9 symptoms, at least one of which must be decreased interest or decreased mood for greater than 2 weeks, you bought yourself the diagnosis of a clinical depression. The more symptoms you have, the more likely you are to respond to treatment. So this says, after many years of marital bliss, tension enters the Kent household, and Lois Lane is embroidering stupid on Superman's cape. Now, I can't tell you whether or not it's Lois Lane is depressed and her Superman isn't so super anymore, or if it's that Clark Kent is depressed and he's not going out and helping people. But I will tell you that it's not that people are taking it out on the loved ones, okay? When you're depressed, it takes so much energy when people say, hey, how you doing? They don't want you to say, oh my God, my life just seems like a deep, dark hole. Do you have an hour to sit and talk about it? They just want you to say, great, how are you? And so just during the course of a day, people who are depressed have to put a lot of energy into faking it. When they get home, they actually are just acting like their normal selves, and that's why their loved ones seem to get the brunt of it. But I hear from loved ones all the time, he's so great when we go out to parties, and then he gets home and he sits like a bump on a log on the couch. That's why. Now, one thing that is very important is this, and this is of critical importance, and it's actually not even being addressed directly. I hope it'll be addressed Sunday during the general discussion. But you know, when you're flying on an airplane, everybody who's flown on an airplane, they say if the oxygen mask dropped down, you have, you should put it on who? Yourself or your children and loved ones first? Yourself. And the reason why is you have about 30 seconds when the oxygen gets sucked out of that airplane before you pass out. And the kids will be screaming, or your loved ones will be screaming, and if you're trying to get it on them, they're going to pass out, you're going to pass out, and nobody's going to make it. If, on the other hand, you put the oxygen mask on yourself first, you can, if you're in for the fight, struggle with them to get it on, or if you have a stopwatch, you could wait 30 seconds, take the easy way out, and they'll be sleeping gently right beside you, and you put the oxygen mask on, okay? But the reason why I bring this up is I will tell you that half the people in the room are the loved ones associated with people who have these CNS autoimmune diseases. And the number of times, I was glad to hear Mr. Abrams say that he takes the phone and calls people and talks to their families. But the number of, show of hands, and we could do this, but just in the interest of time, the number of times that I ask patients, do you go with your doctor to their appointments? They say, yes, I go with my loved ones to the appointment. Now, it's their body that has the autoimmune disease, but you've tied your wagon to that person. But when I ask how many people have actually been taken aside by the doctor separately and said, how are you doing? Are you getting enough oxygen? Are you making sure that you go to your own medical appointments? Are you going out to movies and social events without your loved one to recharge your engine? Because you're no good to them if you don't recharge your engine. I'll tell you, very few people say yes to those questions, and that's critically important. So the caregivers are, unfortunately, a tremendously neglected area. And I'm not going to name any names, Ben Greenberg, but this should be a specific breakout session in future talks to talk about caregivers and the caregiver burden, because we know about things that relate to Alzheimer's disease, but this is very different. These are young people who have families, who are working jobs, very different situation. So it's very important, and I hope that you won't neglect the importance of making sure you're getting enough oxygens for the loved ones. So depression, Charcot is the father of multiple sclerosis. A century and a half ago, he described the very first MS patient ever described by the modern definition of what we now call multiple sclerosis. And this patient was Mademoiselle V, who was so depressed, she got paranoid and stopped eating. She thought she was being poisoned and had to be fed by a stomach pump. You'd think if that was the very first patient ever presented with MS, they might have been clued into the fact that depression might be part of this. It took 115 years to do any research to realize that depression is an integral part of these conditions. And not just integral, 50% of patients, lifetime prevalence at some point after the diagnosis of MS, this is true in TM as well, and the other CNS diseases it probably is, at some point there will be a major clinical depression, and then again, 1 in 4 patients. That's 5 times the rate in the general population. Now here's the problem. The problem is that if you try to treat this symptomatically, like someone comes to you with pneumonia, and if your doctor says, oh, you've got a fever, take this for the fever. You're having breathing troubles, we've got asthma medicine for breathing troubles. You're going to get into real trouble from that pneumonia quick, right? Because you're taking symptomatic medicines that's not getting to the underlying problem. And the problem is that people often come in and they're having trouble sleeping, so they're given something. You say, well, you know, it's tough to have this disease. We're going to give you something to help you sleep, like Valium. Right? Mother's Little Helpers back in the 70s, everybody had Valium. The problem with Valium is alcohol in a pill. So guess what that's going to do to your concentration? It's going to ruin it. But people are going to say, oh, but that's just because of the MS, right? You're having the cognitive impairment. Except the problem with the Valium is then you're very fatigued during the day. And of course, fatigue is one of the 9 symptoms of the depression. So then you get put on a stimulant. And now you're on a Mantidine or Ritalin or some kind of stimulant during the day. Guess what that does to your sleep? Ruins your sleep. So now you got to go up on the Valium at night. And now you're beginning to treat one symptom with another drug for another symptom, all being told that these are just the result. And then, you know, on these stimulants, you lose your appetite and you're not eating and you get even weaker, and et cetera, et cetera. So if you miss the underlying depression, you're actually, when patients come to me, the first thing I often need to do is detox them off all of the pain medicines and all of the stimulants and CNS depressants that they're on to try to get to the underlying condition. So again, I don't have time to go through it. I'm happy to discuss it at length, but we've got lots of evidence that says that basically it's the inflammation of the brain that causes this. Jeffrey Chang, who's here with me as well, is doing research that I'll just briefly touch on, where we're beginning to come up with new ways of imaging this depression in the brain using scanners that are the same scanners that we use for MRIs, but instead of looking at structure, we're looking at chemistry in the brain. We're beginning to actually see these changes in the brain, and it's because of the inflammation that causes it. It has no correlation with physical disability. I mean, I've had, you know, talk to Jim Lubin. Jim Lubin is the TMA website manager. He's been quadriplegic since the age of 19. Isn't that right, Sandy? 19. He's in his 30s now. 40s, 20 years, and you know, Jim's out there working away, not depressed. And so it's not, gee, you'd be depressed too if you were Jim. By definition, Jim, you know, talks about the fact that he was a geek before he got this. He liked to just sit and, you know, listen to music and play on the computer. Now he gets to do it all the time, and as long as he has the support of his family and friends and people like Sandy, Jim is not clinically depressed. So again, it is important. It's the #1 determinant of quality of life in all the studies that have been done, with greater impact than physical disability, fatigue, cognitive impairment, et cetera. It's also the #1 correlate of quality of life for caregivers and their families. So if you're not going to get your depression evaluated and treated for you, do it for your family. And again, as I said, it is a lethal disease if left untreated. 1 in 3 people with MS have thoughts of suicide. 10% of people with MS will attempt suicide. It's the 3rd leading cause of death across the whole lifespan of MS. So again, it is a lethal cause if you don't. It's sort of like the, you know, suicidal thinking, thoughts of wanting to end your life. That for a psychiatrist is like chest pain to a cardiologist. That is a reason that you need to get on the horn and call your doctor. That's an urgency. So of course, transverse myelitis and also the TM, as Sandy described yesterday, that goes with these other conditions, ADEM and NMO and the like, affects everything below the spine. At that level, we did some research at Hopkins and showed this is the general population, and this is mild depression, severe depression, total depression, and of course, MS has a very high rate of mild to moderate and severe depression, and we saw the same thing in TM. We also looked, and the dark blue bars here look like the dark blue bars here, and that just shows you that we saw also that there was some cognitive memory trouble, things on the tip of your tongue that we also found in transverse myelitis. And yesterday, it was interesting to hear Dr. Weinschenker say that they have now described recently that in NMO there is also cognitive impairment that had not been described previously. And Dr. Carlos Pardo, who's a brilliant neuroimmunologist, actually did look in the brains of a patient who unfortunately died as a result of respiratory failure from a very bad case of transverse myelitis, and see this necklace of dark blue cells. These red cells are the red blood cells inside a blood vessel right inside the brain, and this necklace shouldn't be there. These are angry and activated immune cells that are pumping out these chemical messengers that the immune system does. And you don't see this on an MRI, but let me tell you, there's a lot of chemical changes going on in the brain that we can measure, but we're just beginning to put it together in ways of imaging it without having to do a biopsy of the brain and actually see the changes that are associated with depression. So here's the good news. Of course, your daddy loves you. He's on Prozac. He loves everybody. So the good news is that it's treatable. And my expectation is to put everybody back in terms of those symptoms: sleep, interest, guilt, energy, mood, concentration, appetite, psychomotor retardation, and suicidal ideation, to get all those symptoms back to baseline. And so the one question I ask my patients when they come to see me is, what percentage of the way with those symptoms are you back to your old self? And it's very interesting that I'm always amazed how patients can answer that. Meaning, when was the last time you felt like your old self? Well, I was on vacation with my family. We were at, Tijuana. Well, that's a bad example these days. We were in Dallas, had a wonderful time. And I say, okay, great. What percentage of the way back to that person do you feel now? And people say, oh, I'm about 50%. And I say, that's great, except I remember, hasn't been that long since school, and 50% was a failing grade. I'd like you to shoot for an A, right? Let's go for 90. Let's go for 100%. And that is absolutely doable. That's the expectation I have for my patients. So again, www.mood247. This is what Mr. Abram was talking about. This is a mood chart, a mood calendar, and I just look at this and I get dizzy. I think about people who are depressed or in pain or fatigued, and you have to go and get that chart, and you have to fill it out, and you have to remember to bring it into your doctors. So we came up with this way, partnering with Health Central. This is what you see when you log on and you get started, and then you just register, and then as a result you get texted, and you choose what time of the day, when would you like to get your message, and then it says, how's your mood on a scale of 1 to 10. You put that in, and then it gets put into a graph. You can search it like you search your stock performance. You can say the last week, the last month, but you also share it with your trusted circle. Those could be your loved ones. You can follow your children. Parents do this when they send their kids off to college if the kids have had a history of depression. But also my patients share it, and doctors can register and get on, and then you can choose to share it with them. And then when you call them up and say, here's how I'm doing. It's been a month since I started the medication. And I don't know you, I can't remember what I had for lunch a week ago, let alone what my mood was. So, when you're sort of saying how were things a month ago, this is a way of just using what everybody, 90% of the population, has strapped to their waist, a cell phone, to track this information. So last thing I'm just going to end with is just a brief discussion about how we know that the immune system, right? Immune system causes the depression, the activation of the immune system. It's during periods of exacerbation that people are in the biggest trouble. And this is just a recent review that just says that once these cells get into the brain, the immune system actually can cause the depression, but also affects the immune system in general. And that's important, because that means that there's a potential here that things that might affect the immune system might actually affect the depression, and the depression might affect the immune system. Is that true? Well, they drew a tube of blood from patients. Again, this is a study that was done at UCSF back in 2001. We've known about this since 2001. Drew a tube of blood from patients with MS. And then they looked at their white blood cells and they exposed them to myelin. That's what gets stripped off in MS, as well as these other autoimmune diseases. The myelin is under attack. And they saw that those patients who were depressed had twice as aggressive immune cells when exposed to myelin. They treated the depression, and it didn't matter whether they treated it with cognitive behavioral therapy or medications. Those patients whose depression got better, their immune systems calmed down and became normal again with respect to this measure. So it led them to conclude that treatment of the depression may provide a novel disease-modifying therapeutic strategy. Disease-modifying therapeutic strategy is code for steroids or interferons for MS or any of the other treatments that are available, okay? That the idea that treating the depression may actually treat the MS came from this original idea. Now there are other studies that are being done, right? That if the immune system can cause it, maybe treating inflammation will help the brain. So this is Celebrex. Anybody heard of Celebrex? It's a COX-2 inhibitor. It's a pain reliever. This is, off-label use. I want to just tell you that. I'm just showing you some studies. And this basically was a study that used fluoxetine, which is Prozac, with Celebrex, or fluoxetine with placebo. And those patients, even as early as a week to 2 weeks, 4 weeks, and 6 weeks, had a decreased rate of depression on their depression scores if they received the drug Celebrex added onto their SSRI, added onto the Prozac, compared to placebo. And again, the result of this study suggests celecoxib, which is Celebrex, may be an effective adjuvant agent in the management of patients with major depression. Of course, you don't want to just take one study's word for it. You want to see it replicated. And what I can tell you is there's now been 5 studies, all looking at Celebrex. Some were double-blind, randomized, and they look, significant reduction, significant superiority. All of these studies showed benefit. Now, I'm not telling you to rush out and get Celebrex because there's concerns about its effect on cardiac function, and Vioxx got pulled from the market. But I'm just telling you that we're now starting to understand there's a whole new way of treating the depression, which is to treat the inflammation associated with it. So, it turns out that the Up and 7-Up, you know, the Coke and Coca-Cola that added life was cocaine. The Up and 7-Up, by the way, was lithium. And it used to be that we had lithium in 7-Up. Turns out that's a bad idea because unregulated lithium is bad because it can affect the kidneys and thyroid. So if you don't have a doctor measuring the levels, you're in trouble. But this is an animal model of MS, and you can see that these animals were given lithium and these were not. And these animals here, 3 means that they got paralyzed in their arms and legs. And these animals that got lithium didn't. So it turns out it's very effective as a treatment for animal MS. This is a study in humans, and this showed that humans who got Prozac here in the open bars did not get new lesions in their brain with MS compared to those that got placebo. That was a double-blind, placebo-controlled study of Prozac in patients with MS who weren't depressed. Again, suggesting that the medicines we're using to treat the depression are actually treating the inflammation or even the neuroprotection, okay? And then finally, what I'll tell you from our results, these are very preliminary, but these are nerves in a dish. You're not nerves in a dish, so I don't want to generalize. But when you combine lithium and an SSRI, we saw something amazing. These are neurons growing in a dish, minding their own business. When you give them a stroke, half of them die. If you give them lithium and an SSRI, you get more to survive with the stroke than survived without the stroke. We've never seen anything that effective at preserving nerves. So when people talk about progression, progressive MS, progression of disability, these are some of the new ideas for what we can do. And this just shows you what Mood 24/7 can do. These are the first 4 patients. At Hopkins, the star represents where we added lithium to their SSRI, and you can see their mood was going up and down, and it did provide more stabilization. And it just shows you over time that you can use this mood tracking to follow what's going on with people. So, again, I'm not going to have time to talk about it. I'm going to torture Jeffrey Chang and tell you can ask him questions if you have any questions about it, or catch me later. But we are now starting to realize that there's specific regions of the brain, the hippocampus in particular, that we've been visualizing. And we now, again, I don't have time to talk about it, but we actually have an ability to see the depression with a remarkable high degree of sensitivity. By seeing the chemical changes here. It's not ready for prime time. We've not published this. We're just collating and analyzing, but our initial look at the data suggested that we can actually see the depression in the brain of patients with TM and MS, and it looks the same. That's the interesting thing. It's the same kind of changes because the immune system is activated. So final slide, MS, well, almost final slide. MS causes depression, depression worsens MS. Treating the depression improves MS, treating the MS improves the depression, but just remember it's a two-way street. It's very important, don't want to miss it. If you do see it and treat it, it's not only going to help you and your family, maybe save your life, but it also will help the MS. And then this is one of my favorite examples of someone who can show you a different view. Had to face many challenges in my life. I've had to endure numerous physical and emotional hardships, but my positive attitude and my sense of hope for today and the future have never been diminished. My life is good because I will have it no other way. This is my dear friend Paula Lazzari sitting in the back of the room. Paula and Cody have taught me more about TM and about being a doctor than anybody else in any of my professors in medical school. So thanks very much for your time and attention.